Good afternoon to those of you in Singapore, India, and elsewhere. It gives me a great pleasure to welcome you to the first in our series of ISAS webinars on COVID-19 and how it is impacting politics, society, and economies in South Asia. My name is Karthik Nachipan. I'm a research fellow at ISAS, working on India's approach toward global governance and technology policy. Before I go into the details of today's webinar and the speakers, I would like to introduce Professor Raja Mohan, Director, Institute of South Asian Studies, who will make a few introductory remarks.
Thank you, Karthik. It's really just to welcome all of you. This is the first time we are doing this webinar. We hope to do a lot more of these. We certainly find this medium will offer us to reach out a lot more people across space and time. So that I think makes it a lot more openings that come our way in terms of reaching out those who are interested in South Asia, those who are working on South Asia across the world. The crisis today, of course, has been seen as one of a generational challenge, one that is going to alter so many things within countries, between them, and at the international level. We've already seen in India the challenges that have emerged in terms of how to deal with this crisis, the tension between mitigation, suppression on the one hand, on the other hand, the economic costs, and the difficulty, of how unprepared India has been on the public health security issues, and also an opportunity, I think, for India and for a lot of other countries to take this moment to reflect on public health issues and to reimagine, reconstruct their domestic systems, as well as transform their international relations when it comes to health-related issues. I really want to thank Professor Rama Baru and Professor Ramesh Thakur for agreeing to join us this afternoon here in Singapore. And we're really grateful for your support. And I want to thank all the participants who have taken time off to join us in this discussion. So let me wish you all a very stimulating afternoon and a discussion that hopefully will open the door, will open some pathways into thinking about where India is going and how India ought to rework its strategies in a changing world, especially in the health sector. Thank you.
Thank you, Raja. The COVID-19 pandemic has abruptly disrupted all aspects of human life in India. The Indian government has to concurrently stanch new infections, treat rising cases, and contain or sever chains of transmission while managing the economic and political fallout during the currently imposed lockdown. The response marshaled by New Delhi alongside Indian states will decisively shape COVID-19's course and mitigate the damage caused to India's economy, public health apparatus, and social fabric. More broadly, the virus itself could transform India's domestic political economy, patterns of India's existing social contracts, the political importance of public health, and the health provision, and the role of the state. India will also likely face a transformed world, a more polarized, fractious international system. The nature and patterns of international cooperation will likely change to confront challenges like pandemics. There are question marks around the future of the World Health Organization and the international order writ large that has thus far supported India's economic rise. Today's webinar, titled India, COVID-19 and Global Health Governance, we will go in depth into some of the domestic and global governance implications of the coronavirus vis-a-vis India. To discuss these issues, we are delighted to be joined by two speakers who have vast knowledge and experiences in both India, health systems and capacity, and global governance. Dr. Rama Baru is a professor at the Center for Social Medicine and Community Health at the Jawaharlal Nehru University. She has taught the Masters in Public Health, MPhil, and PhD programs in the center for over 25 years. She is an honorary fellow with the Institute of Chinese Studies and an honorary professor at the India Studies Center, Central China Normal University, Wuhan. Her research focus is on the social determinants of health, public health policy, international health, privatization of health services, and inequalities in health. She is the author of Private Healthcare in India, Social Characteristics and Trends, that's published by Sage. She has edited several volumes on school health services in India, on the social and economic context, the medical health insurance schemes for the poor, a co-edited volume with Anuj Kapilashwamy titled Global Health Governance and Commercialization of Public Health in India, Actors, Institutions, and Dialectics of Global and Local, that was published by Routledge. Next, we have Professor Ramesh Thakur, who is Emeritus Professor at the Crawford School of Public Policy, Australian National University. Educated in India and Canada, Professor Thakur has held full-time academic positions at universities in Australia, Canada, Fiji, and New Zealand. He is a former United Nations Assistant Secretary General, the principal writer of Secretary General Kofi Annan's 2002 UN Reform Report, A Responsibility to Protect R2P Commissioner, and with ANU Chancellor Professor Gareth Evans, the author of its 2002 report on R2P. Professor Thakur's recent books include The Group of 20, that's published by Routledge in 2013, the Oxford Handbook of Modern Diplomacy, that's published by the Oxford University Press, 2013, Nuclear Politics, 4 volumes, the latest published by Sage in 2014, Institutional Supports for the International Rule of Law, that's published by Routledge in 2015, and Nuclear Weapons and International Security, Collected Essays, that's published by Routledge in 2015. Before I turn to our guests for their opening remarks, a few housekeeping points for our audience on Zoom and Facebook. Since voice questions will be hard and not very feasible to hear, I would like to request you to go to the chat function and on Zoom and add your questions there, and I will club them together and pass them on to our 2 speakers live. To limit the noise, I will also request you to mute your own audio and video. The agenda for today is, first, both our guest speakers will make a few short remarks, after which I will moderate a discussion on the domestic and global implications of COVID-19 on India, and then we will directly go to the audience Q&A. With that, may I please request Dr. Baru to make some opening remarks.
Thank you very much, and it's an honor and a pleasure to be a part of this webinar of ISAS. I will just make some preliminary remarks in terms of, we all know the epicenter of the pandemic began in Wuhan, and really from December onwards, the storyline of COVID has been fairly consistent and it has gone global. The Indian government, in a sense, had the first response when the Ministry of External Affairs decided to airlift, in the midst of the epidemic from Wuhan, Indian students who were studying there. So that was really the first, if you like, the Indian government's response to the pandemic. Now, many of the students, in fact, were from Kerala. So Kerala's was the first state response. And both the center and the Kerala government created quarantine facilities. And of course, the Kerala government went further by looking at the question of contacts after the quarantine period was over. So I think in the Indian context, the Kerala model, as it has emerged, and India being a subcontinent, we have variety of now models for handling the COVID epidemic. And then the 22nd, when the Janta lockdown was tried out for 1 day, and from 24th to where we are today, we are in a fairly severe lockdown if you compare to many other countries in the lower and middle income country category. So I think these are some of my preliminary remarks, and I'm sure we will get into the details. Thank you.
Great, thank you. Professor Thakur, the floor is yours.
Thanks, Karthik, and thank you, Rama. I think, let me begin with the preliminary observation. All public policy has to be based on a balance of risks and benefits. With a novel virus, as this one is, that means it has to be done amidst uncertainty, incomplete information, but also unintended and perverse human health and economic consequences. And one of the things we see is an abundance of paranoia and fear over fact and reason. Terminology, infection fatality rate, case fatality rate, are the measure of, is one infected individual now additionally infecting more than one person on average or lower than one person on average. And in this, we actually haven't had standardized methodology. And if you look at any of the reports, standard reports for this Johns Hopkins or WHO, you're getting information from different countries. Some of them identify people dying with coronavirus, and others restrict the death rate to people dying of the coronavirus. A good example of the former is Italy, which is why their figure is so high. A good example of the latter is Germany, which is why compared to Italy, their figure is very low. So that makes cross-national comparison very difficult. A second preliminary comment, governments are really being asked to intuit, if you like, the social fulcrum, the sweet spot at the intersection of dangerous complacency that we saw both from Boris Johnson and Donald Trump early on, alarmist panic that we've seen from some others, and reasonable and sensible precautions. Against these, I think what the crisis does is give us an opportunity to reboot the ethic of global cooperation. Because it really has highlighted the need for global circuit breakers to identify, isolate, and quarantine systemic risks, and to do so early and aggressively in order to avoid harsher lockdowns later in the cycle. Therefore, tackling a pandemic, which by definition is an epidemic that crosses several countries, requires cross-border good governance. It requires robust surveillance to detect, test, isolate, and treat every serious case. It requires testing and treatment protocols coming from a credible and central international organization. It requires unimpeded flow of medical equipment and supplies from manufacturers to affected population clusters in whichever country they might be. It requires real-time intelligence sharing and exchange of best practices. And this is why I think, as well as national adequacy measures, and the nation and the state are going to come back, no question. But in addition, we also need, for example, functioning international redundancy in food, health, medical equipment value chains, so that we go in for a risk reduction through diversification by building national capacity, which is different from state power, and by building redundancy in global supply chains. And that means it's in every country's self-interest to recreate a healthy, rules-based international order that breaks down the barriers to the free flow of medical supplies. It should not need a phone call from President Trump to Prime Minister Modi for India to release export of critical equipment. That should be part of the liberal order. Or put it the other way around, Trump's disruption of the global trading order has made it correspondingly much more difficult to organize a coordinated response to the pandemic, or for that matter, for the United States to provide global and world leadership. Instead, we've followed policies of sicken thy neighbor as an adaptation of beggar thy neighbor. And in this, unfortunately, I think the WHO has been proven to be not fit for purpose. And so its advice is being ignored, in some cases even by India, certainly by a lot of other countries. It has, as of today, reversed its decision from yesterday to back China in reopening the wet markets, for example. It's lost credibility. President Trump has decided for the moment to suspend the US funding of the organization. And the biggest scandal with the WHO handling is the way it has ignored what to me so far seems the single most successful strategy, and that's by Taiwan. I think given the context and the geographical location, what Taiwan has done is absolutely astonishing. The WHO should be out there front and center, engaging with Taiwan, studying the lessons, and then disseminating that best practice to the rest of the world. Instead, because of political pressure from China, which we all understand, effectively, Taiwan has been ostracized. And that's a symptom of that. Having said that, as indeed that case indicates, I think we need to be careful that we don't blame the defects of the global architecture of health governance on the organizations themselves, as opposed to the member states who control the policy decisions and the budgets. You mentioned in the introduction, I wrote Kofi Annan's 2002 reform report. We pleaded with member states to increase the regular budgetary contributions and start diminishing the extra budgetary contributions. No one listened to us. Why? Because voluntary discretionary contribution gives them greater control over the agenda and what the organization is going to do, and that they determine on the basis of their own national interests. So I think, as I said, this demonstrates the need for more, but better and smarter global governance, not less.
Great. Thank you so much, Professor Baru and Professor Thakur. So a few weeks ago, Indian Prime Minister Narendra Modi ordered a 3-week lockdown that has thus far been extended till May 3rd, telling Indian citizens that they are not to leave their homes because of the pandemic. So far, there has been around 11,000 confirmed COVID-19 cases in India and about 400 deaths. But a fear of a major outbreak in the country with huge public health deficiencies is likely to have devastating and far-reaching effects. So let us dig into both the domestic and the global architectures and how they're connected here with respect to India's response a little deeper. So I want to first go to Dr. Baru. Before I get into some of the larger implications, I want to ask if you find India's response to COVID-19 thus far efficacious enough, given the lack of focus on testing. Early enough, WHO Director General Tedros exhorted countries to, and I quote, test, saying that this was the backbone of the global response, emphasizing that it was not possible to fight a fire blindfolded, and that social distancing measures and hand washing would not alone extinguish the epidemic. Yet the crux of India's response thus far has largely been a massive lockdown, ostensibly to prepare the health system to test, contain, and treat new infections. But it appears thus far as though the latter part, that of testing, has lagged. The Ministry of Health website shows just a dashboard of the all India data and table of state-wise cumulative figures of confirmed cases, recovered cases, and deaths. It does not provide yet the number of tests that are being done at the all India and state level. So my question to you is mass testing feasible in a country like India? If not, how long can we lock down the entire country?
I just want to go back to what Dr. Thakur said, and I think that's very important because the global story is very much woven into this question of the essentials, the health technology essentials for management of COVID. When I mention as health technology requirements, of course, the testing kits is one part of the story. The other is if hydroxychloroquine is a potential, intervention, that, and very, very importantly, the issue of personal protection equipment for our health workers. So I would like to reply to your testing question by saying that actually that is telling you, if you look at the Indian situation, it is showing you the lack of preparedness. The first cases that came into India from a COVID exposed zone was end of January, early February. We went up to March 22nd, which means really the first phase of the COVID was almost, it at its tail end. And if you look at the preparedness for that, and if you see the kind of testing facilities that were available, there were a handful of government labs that were designated as testing agencies. And that was clearly, inadequate for a population of our size. Then they decided to rope in private laboratories, very few of them. And even till today, there is this long, back and forth between who's going to pay for that. And the Supreme Court has come out with a directive saying it should be free, but there is a whole story after that, which is many of the labs, and the labs, especially in Bombay and other places, have said that, who's going to pay for this? We have already priced the test at a break-even kind of a, cost. Now, for mass testing, we don't have the requisite number of testing kits. Obviously, there's a global tendering. We have ordered for the rapid response kits. But having said that, we've ordered only for 4.5 million. And so how are you going to use it? See, then you'll have to have a strategy. You cannot do what South Korea did because it's just not feasible in a large country like this. If that's the case, what is the strategy you're going to adopt for testing? Are you going to do cluster surveillance? In which case you will identify a contact and then you will test. But there are epidemiologists who are saying that community transmission has already occurred in the Indian population, and there is a proportion of asymptomatic cases. Now, again, if we have already moved into community transmission, then how are we responding to it? How will you see, testing will become much more important. That cluster surveillance will not work if community transmission has already occurred. And if you follow this issue carefully, the states where you're able to do what Dr. Thakur very, very rightly mentioned, of surveillance, of testing, it cannot be a fragmented approach. I mean, you have to have your testing, you will have to have your surveillance, you also have to have your hospital readiness. Now, one of the big stories in the Indian situation is after you test, where are the facilities to even keep the severe cases? And in the Indian context, even if you say about 15 to 20% could be severe cases, the numbers are very large. And many hospitals are very short-staffed and they don't have personal protection equipment. Now, I think this, to me, these are all the signs of a complete lack of a comprehensive preparedness. While saying this, I'm not saying the center can do everything at all, because ultimately health is a state subject. But the center has to take responsibility for financial devolution in order to strengthen the public health system in states who are not in a position to have the kind of preparedness that you see in Kerala. So I think, we are talking about, and in your introductory remarks, you talked about what is the robustness of public health systems. I think globally what we are seeing is the lack of a public health approach is one of the big gaping holes we are seeing in response to COVID. So you can have the best hospital systems in the world, like the Lombardy in Italy. They have a very good hospital system, but they don't have a primary level care. And I think those who are petrified of COVID should understand that majority of the cases will be mild or moderate. But in countries like India and China, where the population density is huge, even a 0.06% fatality rate will show very, very large numbers of deaths.
So I'm really glad you talked of more about the states here. because I want to ask a little more regarding the states and their role in public health provision in India. Now, ideally, the lockdown period should be used by the center to not just break the infection chain, but to isolate those infected from the general population and treat those who require it with varying degrees of hospitalization, including intensive care. But since health is a state responsibility in India, the focus has to be on how the center will work with states to expand health infrastructures, especially for those who need intensive care. But there does not seem to be a concerted effort here on this front. Can you share a little more about what certain states like Kerala have done successfully and what needs to be done more in terms of federalism at the national level?
I think the Kerala, when we talk about the Kerala model, I think we need to
I think you're muted, Dr. Baru.
I'm so sorry. No, I was just saying the Kerala model is really an outlier in the Indian situation, but it is also a very useful example for what we can do and manage in an within the Indian subcontinent. And what I think there is a historical institutional memory of consciously building a functional public health system in Kerala. And that is also because they've had to respond to several epidemics and pandemics in recent times. One of, as you know, they had the Nipah virus, and they had to evolve protocols. They had to very aggressively contain the Nipah virus, and it is seen as a very successful story in public health. The other important thing that happened was the Great Flood. And post-flood, the public health system was geared up to address the potential increase in outbreaks of infectious diseases. So they had leptospirosis earlier. So they've been dealing with a number of infectious disease control at through the public health system. Now, part of the reason for this has also been a very strong political commitment and a political backing for the public health system from the government of the day. And I think the way Pinarayi Vijayan actually handled the entire COVID response much before the center did was not only to look at health system preparedness, looking at surveillance, but they also moved into what we call the social determinants of health. So they had already put in place the release of pensions, they had transfer of salaries, they ensured that there would be support for migrants, range of things which we saw sort of really go awry soon after the lockdown in large parts of North India. And I think those became potential hotspots. Nobody is talking about those as being potential hotspots. When you had large number of migrants just moving in, crowds and then thronging bus depots and railway stations in order to be able to go home. So clearly to me, that was a lack. I mean, I can't believe that we couldn't anticipate that this was bound to happen when you have, population movements of such a large order in a country like of this size. The other model that really has, there have been several models, what are seen as successful models. The other is in Rajasthan. Rajasthan is not Kerala. Rajasthan is a poorer state. The public health system has not been the strongest. And that has been the Bhilwara model. And I think one of the things we must acknowledge is that the health system and the political support for the health system is one part of the story. The other is also the bureaucracy. So, you know, I mean, a good district magistrate who becomes the face of authority and power in a district can plan and administer a response like they had done in Bhilwara. So Bhilwara was a shutdown, as you know, and there was tracing house to house, and there was this kind of forced lockdown that we have been experiencing. So I think there are these two models of management. But when it comes to the question of reporting of cases, to me, that is the weakest link. Now, there was a very good piece in The Spectator from a retired pathologist of the NHS, and he made the point that Dr. Thakur made earlier, and I want to bring that back to our discussion. When you say deaths due to COVID, do you have a category for registering deaths due to COVID? Because, or are you registering them symptomatically? Suppose you have a case of pneumonia who's not been tested. That person gets registered as having died from pneumonia. So, you know, and this was the problem the NHS also faced. So, you know, if you haven't tested someone for having being COVID positive, you cannot have a declaration of the cause of death saying that it is due to COVID positive. And therefore, there may be a lot of underreporting of cases, or like in Italy, an overreporting of cases. So all respiratory related deaths then get registered as COVID deaths. So, I mean, I think this part of the whole story is also very important. It is about science. And one of the things that this sorry, I've forgotten his name, but it's
John Lee.
Oh,
John Lee.
you. Yes. And he basically makes this point, and I'm sure Dr. Thakur can also substantiate what I'm saying. He's basically saying that, you know, you need good science, and you shouldn't sort of confuse good science for quick science. And I think some of this is happening both at the global level and in the Indian context. And I feel that one of the major problems in the Indian context is the opaqueness of the ICMR itself, the opaqueness of the Indian government to say, yes, we have these problems, we may have community transmission, but we don't have to get into this panic and fear all the time. You know, lack of information leads to panic. Misinformation also leads to panic. And if you look at the middle class today, and I live in a colony where I see this kind of panic. So you then start this next very, very ugly side of our social life where you start othering. So the working class is suspect. The minorities are suspect. Anybody who is not you is suspect. So what is it doing to us in terms of our psyche, in terms of our social relations, etc., etc. So, I mean, I don't want to take more time, but we can come back to this, but I hope I've answered your question adequately.
Well, yes, I will come back to you on some of the social aspects of what you were just talking about, but I want to move to Professor Thakur and ask you of the politics of global governance today. The pandemic has underlined that the problems of the 21st century will be unlike those of the 20th. Today, the effects of pandemics and other challenges like climate change and inequality cross borders and require forms of international cooperation that have not been seen in the past, just as you alluded to in your opening remarks. Yet the political appetite and the desire for countries, particularly key countries like the US and China, to work together at the global level is quite low. So far, the principal responses to the pandemic have been either national or subnational, not international. And once the crisis passes, the emphasis will shift to national recovery. In this context, it is hard to see much enthusiasm for, say, tackling global challenges, particularly if it remains viewed as a problem that can be shelved in favor of addressing more immediate problems at home. Do you expect a more parochial, self-interested international politics going ahead, or one that will be more cooperative? Is it possible, in your own words, to, and I quote, reboot the epic of global cooperation?
Yes, it's possible and it's imperative. I think there is a false dichotomy you have laid out there. Let me link it to what Rama was saying. She mentioned Kerala as an outlier among states in India. At the other end, another outlier state is Bihar. I happened to spend 2 weeks in Bihar at the end of February and early March. There is no such thing as public health infrastructure in Bihar. I mean, particularly from a Canberra vantage point, I would have no faith in the public health system whatsoever. I would have no faith in statistics coming out from this very large state in India, with exactly along the lines that Rama was saying, with regard to the causes of death. Most people in Bihar, if they die with comorbidities, it will be kismat or the old age or some sickness. We won't get the things. Now, someone like me goes back and forth because of family reasons. I wasn't even in the state capital, by the way. I was right on the northern border with Nepal. I go back and forth for family reasons. I transit usually through Singapore. Are we really going to lock down countries like India and Indonesia permanently for another 12 or 18 months? If not, these illnesses need to be defeated in these countries. Otherwise, we'll be reinfected in the Western countries. And for that, we have to have international cooperation. I think Bihar as a state government, India as a national government, and globally, we are all going to have to recalibrate in priority and allocation of resources and attention, recalibrate the balance between national security, which has been privileged so far, and human security. And then you bring in health, you bring in environmental issues, you bring in water scarcity, you bring in food scarcity. These are the real threats to the lives of millions more Indians than the notion of a war, whether it's with Pakistan or China or someone else. And we've ignored that. And suddenly we are faced with this crisis. And then we are prepared, because of this gravity, to wreck the national economy, to wreck the global economy. So I think we will need to look at all that. Now, we at the moment underestimate, if you like, the green shoots of international cooperation that are already going on. Scientists from China, from Europe, from the US are collaborating in uploading viral genome sequences. I'm sure Rama has a much more technical mastery over these things than I have. But you have the example of a pharmaceutical company from the private sector in India collaborating with one based in New York in the desperate hunt for an effective vaccine to this virus. You have other examples of this sort of thing. We do have global supply chains. At the moment, we've gone into, we are going to lock this down. But effectively, I mean, we've had this crazy, irrational reaction among citizens of hoarding, for example, toilet paper in panic. We have the same thing internationally with medical equipment and supplies. There's been panic-based national hoarding. It's much more efficient to have an integrated supply chain with redundancy, because you don't want to be critically dependent on one country anymore in the future. But have these global supply chains, identify where you can best produce them fastest and most efficiently, distribute them through global freight networks to where they're most needed. And what we've seen with the virus is that it has not broken out at the same time all over the world. I think the big waves are still to hit, for example, India and Pakistan and Bangladesh. They will come. They've gone in waves. Europe was hit as the epicenter well before the United States. We actually lost valuable time, too busy pointing fingers at China. First, because that's where it happened. Isn't that a terrible system, the wet markets? Then the authoritarian response, tut, 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 only China could do this. And suddenly we are doing very similar things. We could have used that time to prepare much better. Okay, this is now here upon us. not much point in finger pointing regarding the past mistakes, but we have to learn from this, learn to cooperate, because we do live in a globalized world. Yes, the state will come back. Yes, the national state will come back. But we are still going to be interacting with one another. There's still going to be tourists. There's still going to be visitors going back and forth. There will still be the flow of goods and services. We have to recreate a functioning rules-based order with built-in stability and predictability in supply lines, because assuredly, we are either all going to hang together or we will hang separately.
Professor Thakur, so one aspect that could affect the nature of global cooperation is major power relations. And there, so I want to ask you, is major power relations and tensions between China and the United States, and how this discord could affect not just the international order, but patterns of international cooperation going forward. Now, as of now, the United States is not currently disposed to taking on a leading international role. And once this crisis ebbs, I would not expect that to happen either. Some predict that this pandemic will bring about a new patterns of international cooperation, or even a new order that is in some way spearheaded by China. Already we have seen China's influence and role in multilateral institutions grow. 4 Chinese nationals now currently head UN specialized agencies, as you have written yourself. And these are very critical agencies that establish the rules and standards that countries have to adhere to on many number of areas. Now, India generally prefers an international order that is nominally led by the United States and its allies, given how it's performed under it the last few decades, and has sufficient cause to not prefer a China-centric world order going forward. Will these major power tensions roil these new forms of international cooperation that will be required now?
The short answer is yes, absolutely. I think we'll find in the next week or two a lot of articles turning their attention to who are the big winners and losers from this crisis. I think possibly the biggest loser is going to be the United States in terms of its demonstrable incompetence at the top levels of leadership, in terms of its disengagement, and so on and so forth. The European Union also comes out as a loser, because when the crisis came, they went back into national responses rather than a coordinated, integrated response. The transatlantic alliance, I think, has broken down in its solidarity. Interestingly, I think China is both a loser and a winner. And how the balance will work out, we are going to have to wait and see. Surprisingly, in some ways, I think India is going to come out a winner. It's demonstrated the potential to be the pharmacy for the world. And I believe it was Modi's decision personally to reverse the export ban when the President Trump phoned. And he did so by all accounts. And I saw the announcement in some of the Indian papers before the threat of retaliation came. So let's give him credit for that. And it has the capacity to scale up with, the pharmaceutical sector in India is one of the few world-class sector, leading sectors that India has, and it could scale that up. Countries will be more comfortable with building supply lines on this to India now and redirecting from China for a number of reasons. I think another big loser in this crisis has been, unfortunately from my point of view, the United Nations. But potentially, and this is want to finish off in answer to your question, potentially the biggest winner, if it can get its act together, is the G20. Because that's where all the systemically significant countries are members. I was involved in the ideas behind setting it up in the first place. And we were the only group that was advocating for that and identifying various things. And one of the things we did was, it could be any one of several crises that can be the trigger to upgrading the finance ministers G20 to a leaders level. And we discussed pandemics as well. We discussed economic crisis, which is what happened in the end, but we also discussed food security, water stress crisis, environmental crisis, all these we discussed. That's where the countries from the global north and south come together, the most important countries. They will still need validation by the UN system as the universal organization for any decisions they meet. But that's where they can coordinate, get on the phone to each other, have the video conference like they did in March, and agree on certain things. Now, we've had the latest forecast from the IMF, a $9 trillion hit. That's if things go well. And we do have the recovery, a 3% drop in global output. Not even by any means, but you can't, for the first time, you're getting economic crisis in both the developing, well, all of the developing, emerging, and advanced economies. So this is a crisis in which we are all affected. And again, recovery will be mutually reinforcing in a virtuous cycle or mutually undermining in the vicious cycle. So ideally, in the next little while, of all the existing institutions, it is a great opportunity for the G20 to demonstrate the logic behind why we are advocating for that as a global steering group to take us through genuinely global systemic crises. So yes, I think we're going to have to do that. In the short term, we look to our national authorities to protect us as best they can through a regime of test, isolate, and trace. But these are going to have to be complementary if the gains are going to be sustained and not lost with a second wave of infections. At the moment, we don't even know. Does someone who's got it acquire immunity? This whole notion of herd immunity? What's the best balance between the strategy of mitigation and suppression? To collate all that information, we still need some multilateral international mechanism so that the information can be shared and the lessons learned from one country to the other. If they're not, the chances of reinfection will be very high.
Professor Tucker, before I go back to Dr. Burrow, I just wanted to follow up quickly on the G20. So far, it's largely been a body that's focused on economic issues and financial crises without any real structure or institutional edifice behind it. What kind of issues do you think it needs to tackle now? The debt relief for low and middle income countries, providing liquidity for these countries, resisting protectionism. What kind of economic issues do you think most specifically should the G20 take on board right now?
Well, I think the economic crisis of 2008, 2009 was the one that was a trigger to elevating it to a leader's level. But the whole idea, the logic behind it was you had the G7, G8, personalized group of leaders, and the prime mover behind this idea was the former Canadian Prime Minister Paul Martin, and I worked with him in that advocacy at the time leading up to this. The idea was you can have a group of leaders who get to know each other, are familiar with each other, can get on the phone and talk informally. And we would have liked it to be around 14 or 15, but we thought for political reasons it would be easier to upgrade an existing 20-member finance G20 rather than create a new one. But I think it just expanded too much. There's too many stragglers and hangers-on, which I think needs to be pruned back. But also I think with each annual summit, they should focus on 2 or 3 topics and look at topics that are the topics of the day. Obviously this year, the biggest focus, if the meeting does go ahead in Saudi Arabia in Riyadh in November, has to be the virus. And then look at the financial implications, look at the social implications of that, as well as the health, and coordinate responses. Because of the fact that these are countries that dominate the global system in economics, in population, in geopolitical weight, if they agree, they can do things. And the idea of a leaders summit is if leaders sign on to something, the officials below them, and even the other cabinet ministers, have to go along with that. It resolves interagency bureaucratic turf battles. It forces the minds, concentrates the minds of others to do that. And at the end of the day, it's only leaders who can trade apples for oranges and say, okay, we'll do, how is India leveraging, giving aid in some sectors and saying, okay, in turn, we need more, 15,000 more PPE. Can we get that, please? That's the whole idea of being able to do that. And that leaders can do by getting on the phone with each other. So I think they will need to look at that in the short and medium term. But long term, it's the same leaders who will need to talk to one another. How do we now reconfigure the system of global governance so that we address today's real threats and get away from the previous centuries? It doesn't mean geopolitics is gone. It's not. It will be there certainly for our lifetime at least, if not longer. But it does mean we need to find ways to work around geopolitical rivalries and identify functional areas of collaboration where it's no longer a zero-sum game, but where we all win if we collaborate and cooperate and ensure a much more coordinated, efficient, effective, and timely response. Because we don't want to go through this level of chaos and disruption and devastation where whole economies are being laid to waste. We don't want to repeat this again.
Dr. Baru, I want to get back to you. The pandemic has underscored the critical importance of the social determinants of health and the need for a durable social safety net and measures that can protect Indian citizens should a crisis like a pandemic arrive. Now, one of the problematic issues, with the current crisis is seeing the plight of millions of migrant workers who are returning home from the urban areas in India. The urban poor are also facing a lot of struggles. These are largely people who live on daily wages in the informal economy. So the social costs far outweigh the efforts underway to contain the virus's spread. So the scale of economic devastation, particularly for the poor, could change the potential political economy in India and how the government going ahead should support the most vulnerable segments of the Indian population through either additional welfare or insurance policies. Do you think this will happen once the pandemic ebbs, a new social contract between the Indian government and those most vulnerable in the Indian population?
Before I respond to that, I just want to say that one of the things that really struck me when PM Modi made his first broadcast to the nation, the entire tenor of that address was that it's now your personal responsibility. So, this entire excessive emphasis on social distancing and, making sure that you become a compliant citizen in this process. And it was about less government, but better governance. This was the slogan. Now, in any pandemic, we know that if that doesn't work, I think you need to understand that the pandemic itself is telling you that you need more government, but you also need more efficient governance, which means that you have a comprehensive plan on how you bring together the private and the public sectors, the civil society organizations. Because after all, in the last 30 years, our public sector has not really grown. We cannot compare ourselves with a Singapore or even a China. We don't have the kind of public infrastructure, nor do we have the kind of public financing that is required for maintaining public systems. We are a very heavily privatized and commercialized health service system. So in this situation, what I found was, one, that you were putting extraordinary pressure on individuals to be responsible to fight the pandemic. The additional point really is that this really appealed to the middle class constituency of the present government. Now, when you say social distancing, and you talked about migrants, you talked about the urban poor, And here we come to the question of social determinants in health. And I'll give you a couple of examples from Delhi. The kind of settlement patterns in some of the lower middle class, working class colonies are extremely congested. You do have families of 6, 7, intergenerational very often, living together in one room, which serves as both a space to sleep and to cook. You have shared bathroom facilities. Water is not 24 hours like in the private colonies we live in. So there was a very telling photograph with an essay which showed you water tankers in parts of South Delhi. Women were, crowding together to collect water. And you're saying, wash your hands all the time. If you have a family of 6, you're going to ration water for your primary use. Now, where is this whole question of social distancing? And I think this became very, very vivid with the migrants, the plight of migrants who were just walking. Because you suddenly sealed the borders, you didn't have public transportation. You certainly don't have the wherewithal to sanitize all your public transport facilities. So my real, what this pandemic has taught me is how it has brought the class divisions very, very vividly into we are a very unequal society. We have a very self-serving, globalized middle class. This is certainly a huge worry for them. But I see already the hate towards the working class, that they now have become the spreaders of disease. Look at them, they are traveling, they are bringing in their infected bodies, right? So you're already seeing social distancing playing itself out. The term social distancing, which is actually it's a very technical term in public health. It is to do with reducing risk. It is about individual responsibility. When you throw it into a social context, which is highly fractured, you find all these, things coming out. So a lot of prejudices. One is the big China bashing prejudice. I'm talking to you because I've been monitoring WhatsApp messages. There is this, China is responsible for COVID. So, everything, you be anti-China, you're anti-COVID. Then you've also brought in religious symbolism, right? So everybody lights a diya to thank the people who have supported and cared for you, while they don't have PPEs. I mean, what kind of, messaging are you doing? So you stand on your balconies and light the diyas and clang the bartans, and you feel that you have become patriotic. So, there is also this subtext of the metaphor of something like a war. So the COVID virus is our enemy and we are going to defeat this enemy. And I think what Dr. Thakur said is so, so important, that this is a time for dialogue and cooperation, not for contestation and, one-upmanship. We are all going to go. We are all going to go down. None of us are going to be great victors if we don't cooperate and dialogue. But, this kind of using this COVID, in a sense, to bring in rather draconian and authoritarian kind of measures is not okay. And the most recent report, which I have read this morning, is in Ahmedabad. They have created 2 wards, one for Muslims and one for Hindus. So the communal question is a continuing question in the Indian context. So we just came out, we haven't come out, but the CAA protests, on the one hand, that is this entire thing of, registering citizens. And then you have COVID. Then the Tablighi incident takes place in Delhi. Now, everyone in the middle class attributes the spread of COVID and increase in cases and death to Tablighi. What happened with the Tablighi was not right, but it was also an administrative failure, which nobody is talking about. Then we had Ram Navami celebrations in UP. Nobody talks about that. There were 5,000 people there. So, you know, what I'm trying to say is that there is a very selective use of religious minorities, working class. So you have a whole lot of what I would say is very much part of this ugliness of the Indian society being played up and coming up in the minds of people. So, you know, that it gains certain legitimacy. It is okay for you to abuse the working class. It's okay for you to abuse so you're finding the other. And, you know, it is poignant, but when Camus wrote The Plague, this is exactly what he was talking about. And it's quite chilling that when you read The Plague today, you find many of those analogies holding true. And, you know, so, I mean, I just feel that the disruption of the social fabric is something that is really worrying me now. Where even when things come back to normal, how would you look at the domestic help who comes to your home? How will you other them? How will you use protection for yourself, but don't worry about protection of others? The positive side of all of this is there has been, you know, a lot of cooperation from citizens to feed people who are, you know, who don't, and this question of hunger has become very, very important. If you don't have wages, and if you have to wait for hours to get rations, the Delhi government has organized all this. But it means standing in lines for getting your rations. So isn't that antithetical to social distancing? Whose fault is it? The number of public health programs that have been completely put on hold. The child helpline services, the Anganwadi services for child undernutrition, the services for deliveries, the tuberculosis program. So on the one hand, we are a global signatory to stop TB. And we have a public health system today that's only geared towards looking at COVID. So I understand that in an emergency, you would have to do these trade-offs, but to me,
Dr.
these
Bar?
are more, yes? Hello? Hello? Hanging. No, it's not.
Karthik, we've lost you.
I'm back. Am I audible?
Yes.
Am I audible now?
Yes, you are.
Okay. So, I mean,
we lost Karthik though.
Yeah, now Karthik is missing.
Our moderator is missing. There you go. Unmute yourself, Karthik. Okay.
Yeah. Sorry, can you hear me now?
Yep.
Yeah. Suddenly, I think we lost you.
Hi.
No, you're gone again.
Cut. Hi, can you hear me? Sorry.
Yes.
This is the Indian influence drop call.
I just want. Thank you, Dr. Boris. Sorry, something got cut in the last minute. I just want to go to Dr. before I go into Q&A. I wanted to talk to you about the future of global health governance. The WHO, for reasons beyond its control, is now embroiled in a political crisis. Just today, President Trump announced that the US will cut funding for the World Health Organization. Unlike other bodies like the World Trade Organization, the WHO cannot effectively bind or sanction its members. Its authority rests on the power given to it by its member states. So now the world needs more WHO than ever before. Do you think, will we see the WHO wither from more political turmoil, which could lead to new global health initiatives, narrower ones that focus on specific issues like global surveillance, data sharing, health security? So more narrower, a more narrower global health governance.
I think the credibility of the WHO is short for the moment. And that's made it very difficult. You know, we talked about social distancing, for example. It should be the WHO that promulgates the norms for that. I believe their norm is 1 meter. The US is using 2 meter distancing rule. In Australia, we are using 1.5 meter. It's just one very telling example of how the WHO directives are being ignored and countries are going their own way. But once we come out of this, we will need something from here, which is either recreate an improved and better WHO or create a new organization. And that's where I think the key forum for an agreement to go forward with whatever system of global health governance we have will almost certainly be the G20, whether meeting physically or virtually, with new rules, with new funding arrangements for the organization, with new governing boards, and with new voting decisions and some authority for the government, for the Director General. But finally, just one quick point in relation to what you said, Karthik, and that is that it's one of the pathologies of global governance across the board on every topic. Our biggest challenges are all global in scope and require that they be addressed globally through multilateral cooperation. But the legal authority for taking binding decisions and for raising the necessary resources are still vested in states. And this gap between states and the global level, we haven't found a creative formula to bridge that effectively. And that applies, as I said, to all topics. But it just so happens we are facing the consequences with regard to public health at the moment. We lost everyone. You need to unmute again, Karthik. Okay.
Yep. Can you hear me? Great.
Yep.
Sorry about that. So I want to go into the Q&A now. Dr. Baru, can I start with you first? Let's see. We have several questions through the chat. So the first question is, are there ways in which the pandemic and the current crisis disproportionately hurts women? What are the gender-specific dimensions or issues that we need to be aware of in the context of COVID-19?
I think there is some amount of writing that's coming out on this. See, one of the things that the lockdown has done, and it's differential for, I mean, I think there are a certain set of common issues for women across classes. One, certainly domestic work has increased. There is a lot of, tension that comes with living together under the same roof in a lockdown situation. There are reports of domestic violence that has gone up. And because the lockdown has meant no alcohol and no cigarettes and no other forms of, material that normally is consumed by men, there seems to be a lot of frustration growing about not having alcohol. There was a report from one of the states that not having alcohol, not being able to go out and have a social life produces a number of tensions. And the third aspect, which is also being highlighted, is children being trapped in homes. and there is also growing child abuse. So, there is this, the dynamics of a lockdown are not just about keeping people in their spaces. Sometimes the home is not the best space to be in, and especially for women and children. And the third group of people whom we are not really addressing is the elderly, the aged. And I think even under normal circumstances, there is a considerable amount of neglect and abuse of older persons, even within families. And there are also elderly who live alone. There are single elderly. And there have been reports from, the homes for the elderly. There are a few anecdotal reporting on that, where the elderly are actually, the homes are not able to procure adequate amount of food to feed them regularly. You see, there has been a lot of goodwill. There have been NGOs, there have been even, people just coming together and trying to address this question of hunger and not having adequate food by actually making food and then distributing it. But that's not a solution. We are going in for another 2 weeks. And there is something called fatigue that sets in. And I think we are already seeing signs of this fatigue. There are many more reported quarrels in families. And I think this is really, it is partly the fear of COVID, maybe. And psychiatrists who are writing about it are saying anxieties are much higher, fear is much higher. But it's not just COVID. It is being trapped in your home, not having your work routine, not having a social life, not having social interactions. And not everyone can do WhatsApp calls and, be on telephones. So I think there's been a lot of disruption. I mean, I can see it for myself as a professor in a university. All our classes are supposed to be transacted in a virtual mode. In contexts where our students are in Bihar and parts of West Bengal where internet connectivity is very poor. These are students who have prepaid connections. It's impossible to have any discussion virtually. You cannot teach a class. And then you are supposed to evaluate them. So I'm saying that there have been these many layers and levels of disruption, which I'm sure is going to be talked about much more. In fact, in the New Yorker, there's some very, very heart-rending pieces on what it means to be elderly in the time of COVID, what it means to be homeless in the time of COVID. So, it's really, there are a lot of disruptions socially, and I think we take many of our social interactions for granted. But when the lockdown comes, then you realize how paralyzed you are and how you're cocooned. And I think most of us don't like to be cocooned.
Professor Thakur, the question for you. Should we expect the global health discourse and global health governance landscape to be far more securitized than it is now, which could affect how open countries will be in working to manage problems like surveillance, flow of medical equipment and supplies across borders, intelligence sharing, and the need to erect new norms to manage outbreaks, further outbreaks coming in?
I think it's possible that we may go down that route. I think the correct lesson would be the need to de-securitize existing global governance mechanisms for dealing with, as I said, the human security issues. Obviously, there is an element of strategic competition, particularly between the United States and China. There will be decoupling as far as the extreme dependence is concerned on China for critical supply lines. On the other hand, it is actually quite heartwarming, despite the geopolitical tensions, to see images of Chinese deliveries to the United States and to Australia, and Russian planes landing at JFK in New York, delivering vital supplies. So there are hopeful signs even there. I think if we securitize the human security issues, we will have much more competition. If we decouple geopolitics from human security issues, we might have functional collaboration on issues in which we share common threats. I mean, look, these are threats and enemies without borders. As Kofi Annan said, we have problems without passports. They require solutions without passports. And that will be the most, on the logic of the free market even, that will be the most efficient. But China, for example, as a result of a bilateral dispute with Japan, going back 10 years ago to 2010, concerning a boat in the disputed seas, exercised its leverage arising from control of rare earth minerals. It turned out China produced 97% or something like that of rare earth minerals, and they were critical for Japanese high-tech manufacturing equipment. And that made Japan very vulnerable. Now we discover we are vulnerable on other things. Clearly, all countries are going to react in two ways. One, rebuild national capacity. I think one of the, by the way, going back to my winners and losers, one of the big losers from this, I think, will be the extreme, pure neoliberal free market ideology. History is going to accelerate, not just restart, going back to Francis Fukuyama. And we're going to recalibrate the relationship between the private sector and the public sector. One of the big advantages Taiwan has had, we've been impressed by China's capacity to manufacture and field within 7 days or 10 days an entire new hospital in Wuhan. Taiwan didn't do that, but what they did, while the WHO was advising to the contrary, they started testing passengers coming in from Wuhan. Let's remember the facts of Taiwan. It's very interesting. You have 1.2 million Taiwanese living or working in the mainland. You have between 3 and 4 million travelers going back and forth. This crisis hits just before the Chinese Lunar New Year, when families go and visit each other. The WHO is saying we have no reason to suspect human-to-human transmission. Taiwan, learning from the SARS experience, said no. They started testing every incoming passenger flight from Wuhan, which is, remember, one of the 4 major transportation hubs in China. They started testing. They activated. Now, they were fortunate in that their vice president, believe it or not, has a doctorate in public health from Johns Hopkins, one of the world's leading medical universities. And they activated their National Epidemic Command Center, or whatever it's called. Within 1 day, they managed to connect and integrate their health service, which is a national health service. So countries that have private health schemes that don't collaborate won't be able to do it. But they integrated the records from the National Health Service with the pharmacies across the country, and with customs and immigration travel records going back 14 days. And they managed to do that within 1 day. Then they went in for very aggressive and early testing, isolating, contact tracing, and using mobile phones, tracing where people were going to. They ramped up production capacity. They banned mass gatherings, but they also introduced testing equipment, not just at airports, but in shopping complexes, in office complexes, in any place where, transportation hubs, obviously. And they did all that. So you can do all that without going the full lockdown mode. And they have been, as I said, on all statistics. And their statistics are far more reliable than what we're getting out of India and China for different reasons. By all statistics, they've done very, very well. Now scale that up to the global level. We should learn that collaborating and cooperating will be to the benefit of all of us. We can, of course, build national capacity. We can go behind fortress walls at the border. That will be inefficient, ineffective, and it will be to the damage of all of us. So I think, as well as decoupling from China on the strategic side, we need to identify ways of decoupling geopolitical tensions from functional collaboration, because in the second one, it's a win-win outcome, not a win versus lose zero-sum game.
Dr. Baru, there's a question for you from Anupam. Can you indicate how the primary health centers have performed across different states, so the PHCs? And have private hospitals and insurance made health the luxury of those who can afford it rather than the need of the larger community?
The primary healthcare system is extremely varied in India, and I think it'll be a little difficult for me to sort of summarize it in a short period of time. But I would say that one, there are clearly interstate variations, and there are very good performers which we traditionally know from the southern states of Tamil Nadu and Kerala. Maharashtra is, I mean, I would say Karnataka, Maharashtra would follow. But I think our real concern about the primary healthcare system is in the Hindi, what is described as the Hindi belt. And there has been a weakening of the public health system, which is not something that has happened today. It began in the 80s. So the investments into public health have been limited, and disease priority programs have overtaken the primary healthcare system. So when you had a polio program, the public healthcare system was completely geared towards only doing polio. And that meant that all general health services were neglected. So in a sense, if COVID takes over, then the public health system is looking at COVID. I think we have an extremely commercialized health system in India. And I do not see, if you look at the National Sample Survey data on utilization, it is not only the rich who are using the private system. And I think we need to look at an extremely heterogeneous private sector, the market which corresponds to the needs of a highly stratified society. So you do find both for outpatient and inpatient over the last 10, 20 years, there has been a greater dependence on the private sector. The public health insurance schemes like the Ayushman Bharat, or before that the Rashtriya Swasthya Bima Yojana, have actually privileged the empanelment of private hospitals in a highly unregulated manner, meaning the private sector is itself highly unregulated, and public insurance schemes have sort of flowed public subsidies into the private sector. And even during the time of COVID, we could have used our National Disaster Management Act to requisition from the private sector. I'm not even talking about nationalizing the private sector, which is what they did in Spain. But we could have requisitioned very effectively the private sector. Now, what's really interesting is that in the recent reports from Mumbai show you that there was really no sharing of clinical protocols and standard operating procedures for COVID, even to the private sector from the central government, because both two very large and well-known tertiary hospitals in the private sector in Mumbai, among many others that followed, have closed down because they had their workers infected with COVID. And the workers say that they didn't get the protection equipment that was necessary. So, we are having a situation where the internationally accredited hospitals themselves were not prepared. Some states have roped in the private sector, like some parts of Kerala, the Bilwara model in Rajasthan. There was an attempt by the Chhattisgarh government to rope in the private sector. But ultimately the private sector can cop out, but public responsibility remains with the public system. So if you're a doctor in the public sector, and if you say that I don't want to serve because I'm afraid I may get COVID under the circumstances of poor working conditions, you can actually be hauled up. But a private hospital can shut its doors, saying that we are doing this in the interest of public safety. And nobody is talking about who is ultimately accountable and how do you ensure that you bring in both the public and private sector, not just the large private sector. Because if you go to parts of Bihar, you don't have a large private sector. You have maybe small nursing homes, and you have a very large informal private sector. And it is here that people who have even COVID symptoms will be going for treatment. So, this question of surveillance is also linked to the structure of the health services as we have them today. And so, I mean, we lost an opportunity to rein in the private sector.
Dr. Baru, I have one question which I'd like to share between the both of you, because it concerns something that has both domestic and global implications. The question is, how long are we going to have a shortage of PPE in India to deal with the current crisis? And obviously the current shortages within certain countries are tied to existing supply chains of medical supplies, which are being affected because countries are limiting the trade of some vital health supplies and materials. So, Dr. Baru, I guess that question directly in terms of India, how long are we going to have a shortage of PPE? And Professor Thakur, do you expect more export controls to be in use by countries in terms of vital health equipment and supplies like PPEs, drugs, but also when we are moving closer to a vaccine? Do you expect countries to employ export controls to restrict the overseas flow of vital health supplies? So let me go to Dr. Baru first, and then Professor Thakur after that.
There is actually very little transparency in the quantum we require for PPEs and what is actually available. But I can only tell you that I think different institutions are innovating differently. Right now, the All India Institute of Medical Sciences is saying we can reuse by using proper sterilizing procedures, gowns and masks and things like that. But we know that we've been told that they are ordering PPEs. And somewhere I also have a question that you have army production units, the defense DRDO type of institutions. Couldn't we have mobilized them to produce PPEs locally? And I don't know where we are procuring our PPEs from, but we know even with PPEs in place, health workers are contracting COVID. I mean, you're dealing with like Dr. Thakur rightly said, you're dealing with an epidemic and a virus, the virulence of which we know something about, but we don't know fully about. And now we also know there are mutations of it. So you have the virulent strains and maybe you have the not so virulent strains, but who knows how this whole thing is going to span out. And therefore, this PPEs question is very, very critical for the future of the morale of the health workers. Because, we talked about how there is tension and fear in the case of, social interactions. But the health workers are in a very difficult predicament because there are already reports from the Indian media that patients are attacking the health workers, saying, you are going to give us COVID. And what it is then doing is, there is fatigue, there is also, lack of morale, and there is fear in themselves. So there are accounts from resident doctors and nurses saying that, they are performing their duties, not knowing if they will succumb to the illness themselves, and then what happens. So I think the PPE story is absolutely critical. If the government is not able to secure the safety of your health workers, then what are we talking about?
Dr. Thakur, can I just have you talk about the export controls part of vital health supplies that countries are going to need, not just now, but in dealing with this epidemic for months on end?
We had that very heartfelt thanks from Prime Minister Boris Johnson after he came out of hospital, where he thanked all the National Health Service staff and mentioned two in particular, one from Portugal, one from Invercargill in New Zealand, which is a part of the world that I lived 15, 16 years, so I know it well. And that was important. I hope this crisis in India will lead to a re-evaluation of public attitudes towards healthcare workers, including in the primary healthcare, which is where the average citizen actually comes into contact with the public health system, and elevate their status and improve their compensation with regard to wages and salaries and facilities and so on. As I said, a better understanding of the real threats to people's security. I think there are two bits of good news globally. One is that in most of the Western countries, we do seem to have peaked and flattened the curve, to use the expression, where the number of new cases now are lower than the number of cases no longer active. And if that stays, the urgency of the requirement for equipment in the Western countries will diminish. At the same time, all countries are trying to ramp up production. Rama mentioned the example of the military in India. Well, again, one of the things that Taiwan did very early on was to draft in all the reservists and get them to staff the production lines for PPE equipment. So there is things that can be done. And one of the things that India has done quite innovatively is with the railway carriages, with the railways lying idle, 20,000 railway carriages with a 3,300,000 bed capacity are being redeployed as effectively mobile isolation wards. So I think all countries are going to think creatively and innovatively, but as the geographical location of the population clusters still being infected or still suffering from this begins to shift, and we go through 3 weeks, maybe 4 weeks of continuing to decline to virtually no new cases, I think we will see a greater willingness to start easing export restrictions and sending them to where they're most needed, both out of generosity and a sense of human solidarity, but also out of self-interest. Because if we don't flatten the curve in India, speaking as an Australian, if we don't flatten the curve in Indonesia, then our chances of being reinfected by people going back and forth between these two countries, and China for that matter, is going to be very, very high. So it is in our collective self-interest to balance national requirements between different countries to make sure that we address this threat globally, not just in a sentimental name of humanity, but for very practical, hard-headed, national, self-centered reasons. We need to eliminate this as a threat, bring it down to levels where it is no worse around the world than your average seasonal flu. And of course, on that point, Europe and North America, at the present epicenters, are now coming out of the winters. We are going into our winter, so we might get a spurt or surge in flu cases and possibly in this particular virus. But the real population densities are coming out of that. So that will also help to reduce the intensity. And we still don't know really. I mean, from what I understand, viral epidemics are rarely both highly infectious and at the same time highly lethal. The Spanish flu or the great 1918 pandemic was an example of that. As of now, we don't know that applies to this particular, to the COVID disease. It may not. If it doesn't, if it's highly infectious with a lot of asymptomatic cases, but not as highly lethal as we feared. And at present, most countries have not had to experience the worst case scenario of surge and steep soaring of cases and lethality that they're fearing. If that stabilizes and goes down and disappears, I would be very surprised if we didn't start easing export restrictions, even with ramped up production around the world.
Well, I'm afraid we're all out of time now. This has been a fascinating conversation. on the domestic and global implications of COVID, of which there are so much. There is no easy solution here with respect to COVID-19. In fact, there is no end here, but just a continuation for now. All countries will have to learn how to live with COVID-19 over the next few months and possibly years. These months and possibly years ahead will involve, as our speakers have mentioned, a fragile balancing act between the interests of public health, society, and the economy, with governments more reliant on each other than ever before at the international level. New approaches to political and economic governance, possibly new social contracts, new ways of providing support to those most vulnerable amongst us, new patterns of working with countries to get things done. The post-corona world that India and a lot of the other countries will inhabit will be far different than the one that they inhabit right now, both internally and externally. And it has been a great delight to explore that in some great detail with our two guest speakers this afternoon. So please join me in thanking our two very special guests, Dr. Rama Baru from JNU and Professor Ramesh Thakur of ANU, for this invigorating web seminar. And thank you again for joining.
Thanks, Karthik, and thanks and bye, Rama.
Thank you very much. It was a pleasure meeting both of you, and I really enjoyed this conversation. Thank you so much.
Thank you again. Thank you, Dr.
Bye.